on the ward. So my name's James. I'm one of the clinical lecturers in Oxford. I think you've met a couple of my colleagues, but you're very welcome to email me afterwards if there is anything that I've not covered or I've confused you about, and then my email address is there. That said, I think the other thing to point out is that these lectures are what we basically deliver to the Oxford medical students before they go out and see patients on the ward. So they get 2 weeks worth of lectures, of which this is 2 or 3 lectures worth. And then they get 4 weeks seeing patients on the wards with some bedside tutorials and discussions with the doctors that are seeing patients. So this will never replace you seeing patients. It will never replace your face-to-face learning and memory of what happens when a child is unwell. I guess most of this lecture is kind of predicated around undergoing an A2E assessment and your knowledge of what an A2E assessment is, which I assume you know already, and it will be basically the same as you've learned for adult assessments. So you work through your A2E. This is obviously not for trauma. There's a sort of catastrophic bleeding at the top end and stabilizing a C-spine, but for most medical assessments, it's the things that are going to kill you in that order. So loss of an airway, and then whether the child is breathing appropriately or not. And then you work down to circulation, disability, as in neuro disability typically, and that's their conscious level. And then we also say D, E, F, G, don't ever forget the glucose as part of their neurodisability or neurocognitive level. You know, having a low GCS can be a result of a low glucose and other electrolytes. And then E for exposure. Are you missing any funny rashes? Are you missing an kind of blown up tummy or a stoma that's actually suddenly started going out? So it's important to fully expose the child. So all of this is taken as a given, and we're going to move on with some thoughts around how you approach children as opposed to adults, which you'll have spent, I'm sure, most of your medical student career to date thinking about. And it's similar, but definitely not the same, and they behave quite differently. And we're particularly keen on you thinking about children as a different approach to how you would an adult. So what's in F2? So an F2 is a PGY2, a second year doctor. So they've just done 12 months of postgraduate doctor training. And so they're in the emergency department, and this is you now. This will be you shortly, I suspect. And you've got a call by the nurse in charge, who is essentially the most senior nurse in the department, seeing children, and they're worried. So if they're calling you, they're worried, and they want you to see a child that they've just triaged, and they're very worried about it. So I think one of the take homes, which I'm sure you'll have already captured, is if the nurse is worried, you're worried. They know what they're doing, and they've been doing it probably for longer than all of us. So they've seen a 6-year-old boy who's normally fit and well, who's been brought in with fever for a couple of days. Mum drove him into ED, and he didn't really wake up, and he was a bit drowsy, and he's been vomiting all night in the car, and in the car, sorry. And so he looks like this. So you walk into the room, and this is him. This is obviously not him. This is a picture off the internet, but this is what he looks like. And he doesn't seem to really notice you walking in the room, and you're obviously a stranger to the 6-year-old. So this is where you get to shout out. Are you worried or not worried? Anyone?
I would be worried.
Yes, please. Yeah, please do be worried. Especially if you're nurse in charge. Our wonderful nurses who spend all of their lives caring for children have some concerns, you know. So if the nurses are worried and they see sick children all the time, then you're worried. So this is a child who is not responding normally, and they have this funny rash. So what are you going to do next? You've got a list of options here. So you could maybe have a break. You can panic. You can take a blood glucose, you can start some oxygen, you can take a history, you can wait for one of the more senior doctors to arrive, you can assess the ventilation, or you could put in a cannula and take some blood tests, or you could go and speak to the radiographers and try and find a CT. Lana.
I think I'll have to go with the basic ABCs for the airway and breathing and circulation, and see if the patient is conscious, oriented, decreased level of consciousness. On the side,
Absolutely.
and on the side we'll have a side of panic.
Yes, yes, you're allowed to panic. That's completely fine. Yes. And I think you
Yeah,
should be,
so
as part of that worry, there is a degree of panic, isn't there? So there's worry, there's panic. So you're probably going to do a bunch of these things.
yeah, and
And you're
then we'll
right. So,
head to the history. We'll
yes,
try to
eventually.
see the parents and or the guardian, and we'll try
Yeah.
to talk with the patient alone, also without the guardian.
You
And
don't have to. I mean, so in this setting, they're going to be scared, so I wouldn't necessarily separate them. But a bunch of these things is the right answer. Probably not the go and have a coffee break. You're allowed to panic, but probably not for too long. And you probably want to have a senior help. The history comes a little bit later once you started to do that A to E assessment. So yeah, absolutely right. And I guess the point we're making is that pediatric emergencies are scary. Children are not meant to be unwell. So older people with lots of comorbidities, it's not actually completely unexpected for them to end up unwell in hospital. And as adults, we sort of cope a little bit better with that. And I don't know how many of you have children or have been around lots of children, but children are, they're unwell as in they have the sniffles and colds and they feel a bit miserable and they get tummy aches and things. But coming into hospital and being very unwell and ending up in A&E and ending up with the nurse in charge worry about you is rare. It's unusual. We have a general hospital here, so we have a hospital that's mixed with adults and children, and there's a children's hospital attached to it. But we mix ourselves, and so of the hospital of about 10,000 beds, we have maybe 10%, maybe less than that. We are and that's obviously we're a big teaching hospital, but every hospital that has adults and children in, a very small proportion of that hospital is made up for children, even if a fifth of the population are children. So it's unusual to see children unwell. So it's normal to be worried. And what we need to give you is the skills and an approach as to how to tackle that. And that's something that you'll build on for the rest of your careers, depending on how much you see children or adults. But the other key thing to note is that they will keep going. And this is probably not your generation, but Roadrunner was a popular cartoon back in the 90s. And it would keep running off a cliff. And that's what children do. They sort of keep going until actually they just reach the end. They have much more compliant vascular systems. They're much more able to centralize their circulating volume, despite it being in the wrong places or missing some. And they will keep going and become tachycardic, and their blood pressure will be stable. And then it just stops and they will arrest. So they will keep going for a long time, and it gives you a little bit of space, but actually they will fall off a cliff very quickly if you're not wary of that. We talked briefly about ABC, and obviously this I'm going to take as a given that you know how to do an ABCDE approach. But we want to give you a little bit more structure around how to work through that. So we're going to suggest that you go for each of those a look, particularly in children, because they don't like you touching them. And if you're a scary stranger and you're already unwell, you probably don't like someone coming in and swooping in with a stethoscope on and scary hospital clothes, especially if they've been here before. So actually children will give you lots of signs if you just stand back and look and potentially listen, and that includes auscultation, obviously, and then you might have to feel, and then there's some measurements that might be going on simultaneously. Your wonderful nurses might be already setting up the cardiac monitoring or the blood pressure cuff or SATS trace. And then you need to obviously do something to make them better, because that's why we're here. And probably not what we're going to do today is the sort of resuscitation algorithm. So I'm not going to teach you, cardiac arrest algorithms. That is all very algorithm based. You're going to learn to be doctors, so you want to do more than just what the algorithm says and following an algorithm, and when you give adrenaline and when you give amiodarone. So we're going to have a think about a sick child and how to approach them, which doesn't fit into an algorithm. There's usually a guideline somewhere, but you have to do a little bit of diagnostic acumen first. So how do we approach the child's airway? So obviously look. I'm going to make you say some of them in a second because I'm going to get bored of my voice. So look, what are we looking for in the airway? So we're worried about any kind of obvious swelling, edema, angioedema, could be from anaphylaxis, could be from hereditary forms of angioedema, could be from something funny that they've eaten some sort of toxin. And then facial trauma, neck trauma, obviously that is all going to be obstructing the airway. So the next one is listen. What signs might you hear on a pediatric airway that you would be concerned about or concerned for? Is all top end. So clinical signs that you would hear on a pediatric airway. I'm
We
thinking
might hear
so.
like wheezes,
The wheezing,
stridor.
I'm thinking lower down. Absolutely, stridor. Yep.
Yeah, and barking cough and
Yes, yes, yeah. I mean, I guess you could say barking cough lower down as well because the cough, but you're right, the barking cough because of the stridor, because of the upper airway constriction. And snoring is the other one that we put here. You know, this is collapsed upper airway, so sounds on both sides. This is someone who's got potentially a dropped GCS. Might be normal for them. But if they're not waking up and they're snoring, then that's a bit of concern, isn't it? And then feeling, there's not a huge amount to feel for airway, but you might feel for their tracheal position. I wouldn't in a lively, active child that's screaming at you already. But for a child with a low GCS or a child that you're already very, very worried about, you want to know where their tracheal position is. There's not much to measure other than that scream, more in B, though, isn't it? And then
I mean,
treating.
it's good if he's screaming. That
If
means
they're screaming, then you've got A
he's
and B
breathing.
covered. Yeah, absolutely. Yes, if they're shouting at you already, then you've got A and B. If they're also barking cough, then you're a bit more worried about A. And in terms of treating, so treating the upper airway, it's there's limited options, but you're going to do some simple maneuvers. So head tilt, jaw thrust. We'll talk briefly in a second about the positions you want children of different ages to be in. And there's some airway adjuncts. So there's Goodell's, there's laryngeal mask airways, LMAs, and then there's obviously advanced airway in terms of intubating, which we wouldn't normally do as medics, but we do in babies, and we would expect an airway specialist to do that usually in ED or an anaesthetist to come along. So if we're worried about these things, then we're going to get a specialist to come and preserve the airway.
Can I ask about the Goodall? I don't want to sound like I don't know what it is. It just
No, I was wondering about that earlier and whether that's a sort of brand name specific. I think it is a brand name. Probably the best way to do it is look it up. Let me just quickly Google it, a picture. I was thinking, should I put a picture in this? Because will you guys know what Goodell means? I don't know if that's a specific kind of British brand that we use. It's essentially a rigid kind of tongue depressor and upper airway creator, and it's not as good as a laryngeal mask airway, but how do I do that? View image. Let me just think because I'm sharing the
thank you.
window. These are what Goodells look like. So these are Goodell airways of different ages. And can you see my mouse? I can't tell.
Yeah, I can.
Where
Thank
my
you.
mouse so that's the airway end, that's the mouth end, and then the tongue would be under there. So you put it in upside down. So you put it in pointing up to the roof, and then you turn it over. And so that's pointing down
Yeah,
toward.
it is the oropharyngeal airway, isn't it?
Yes, or yes, OPA.
Yeah, okay. Yeah, got it. I was
Sorry,
thinking
we
the
end up
same
using
thing
brand
when I
names
saw
for
a
a few
picture.
things, and we're normally quite sensible about not doing that. But sorry. So yeah, this is an OPA. It will be on your trolleys. They're not as effective as LMAs, laryngeal mask airways, which we're using much more readily. And actually, they now go down to less than 3 kilos. So we almost never use these, but they're a get out of jail free if you're looking for it and you're hunting in your trolley for one.
Okay, thank
Anyway,
you.
B. Right. So what are you looking for in B? And B is a very generous sign in children.
But like we can look at any like asymmetry on the chest, and we can look at like how is breathing, is it tachypnea, or
Yeah.
are they shallow, are they deep and lethargic?
Yeah.
Signs of respiratory distress in children. Yeah, it includes many things like nasal flaring and subcostal subcostal retractions, intercostal retractions, substernal. So
Yeah.
this is regarding the law.
Yes, yeah. Sorry, I've just found the chat box. I'm excited. I can see you guys talking as well. Amazing. Yeah, there are loads of signs, and you're right on all of those. So asymmetry we don't often see. I mean, that's I guess a sign in trauma or a sign with a pneumothorax. But children are very generous with lower respiratory signs. I guess we see lots of these because of winter bugs causing respiratory distress, often viral wheezing. And so we see this very, very commonly in the UK. And I guess bronchiolitis in babies, newborn babies, we often see with restricted lower airways and mucus that needs to move, particularly C-section babies. So breathing is somewhere where we have loads and loads of signs. Someone's put here accessory muscle use, exactly that. And what have we got listed here? So there's a very, very brief list here. Yeah, cyanosis, quite right. So yeah, asymmetry, deformity, breath quality, shallow, deep, yeah, and accessory muscle use. And people often refer to that, particularly here, I don't know how common this is, but work of breathing is what people talk about. So we talk about increased work of breathing. And I mean, wouldn't describe the child as work of breathing, but it's increased work of breathing. And obviously they can become cyanotic if there's really, really kind of type 2 respiratory failure. Increased work of breathing is the kind of generic sign for they're working harder, and you sort of start to get a sense of what that means. But often it is recessions between ribs, recessions as in impression, what am I trying to say? Kind of a recession around the trachea. So this is subcostal and so subcostal being below the diaphragm, intercostal around the ribs, and tracheal tug, so tug around the trachea, subcostal recession, intercostal recession, sternal recession, and those recessions is essentially just a depression where there is massive, massive negative intrathoracic pressure created, and that's them trying to get air in past some sort of obstruction, whether that is restricted smooth muscle in the upper part of the lower airway, kind of due to bronchospasm, asthma, and viral wheeze or bronchiolitis. But that massive negative pressure means that they are not successfully sucking all the air in, but they are sucking all their kind of tissues from externally in, and they have excellent signs. And we've got a couple of videos to prove that. I'll whiz through the rest of these. Bradypnea after accessory muscle retraction means that the child's in a bad state. Yes, very good. Yeah, I mean, if they're exhausting and their respiratory rate is slowing, you're in a bad place, a very bad place. So initially you would expect a child to have a low CO2. They're blowing off their CO2 if you do a blood gas, because they're breathing so quickly. So they're obviously either acidotic or they have restricted airway, but they're breathing quickly. When you start to see the CO2, so that's the peripheral blood gas CO2 normalize, you start to become a bit more worried. And as they tire, their gas exchange gets poorer and they are getting tired. So either actually even normal respiratory rate when you know they've been tachypnic, or if they start to slow their respiratory rate, you're in a bad place. That said, obviously this is all age specific, so you need to think about your normal ranges for age. So a newborn baby breathing at 55 breaths per minute is normal. It sounds fast, but it is normal. Whereas a 16-year-old breathing at 20, 25 breaths per minute is fast or faster. Okay, so what we're going to listen for breath sounds. That includes things like wheeze, crackles, dullness, transmitted airway sounds. Feel for chest expansion. Again, thinking is it bilateral? Feel for resonance. So if they are older and able to talk to you, you can feel for vocal resonance. And measuring, so you can measure from sensible things here, and you can measure their respiratory rate, which is a sensitive sign that we often forget to do, but the nurses are excellent at doing. And SATs tend to draw your attention because they're on the screen or they're on the monitor, and they tend to be flashing or alarming. And treat. So obviously you can start by providing oxygen. And sorry, these are unhelpful abbreviations. So this is providing oxygen by a non-rebreathe mask, which just essentially is the highest way we can get oxygen in without invasive ventilation. and then bag valve ventilation or intubation and ventilation. So bag valve ventilation, bag valve mask is when you're obviously manually ventilating the child that's collapsed and not breathing anymore, and intubation and ventilation is when you intubated them. Okay. So lots of B signs. We will show you lots of B signs in a sec. Circulation. What are we going to look for that suggests that a child has an abnormal circulation? Carotid pulse. That's probably more of a feeling one. Cyanosis. Yeah. So they might be peripherally cyanotic, centrally cyanotic.
I would
Heart
see
rate.
if the patient is pale or cold extremities.
Yes,
And
exactly that.
I would see for capillary fill time if it's delayed.
We're straying into the feeling a little bit, but absolutely. So cold extremities. So you can look, you can see if they're peripherally shut down. So if they've got mottled skin, that suggests, I mean, we're sort of a little bit treading on exposure there. What have we put here? So pallor cyanosis, jugular venous pressure, you're not going to see in most children. You're not going to get a great JVP. It's not a big part of our examination. They might be diaphoretic, and particular children in heart failure will be diaphoretic, so sweating a lot. But pallor, cyanosis, and I completely agree, that sort of shut down look where you start to see the more and more shut down as you find, and you can, when we get to feel, you're feeling definitely for that capillary refill time. So that's that, press for 5 seconds, release, and count properly seconds. So Mississippi or elephant, 1 elephant, 2 elephant. And you should have a capillary refill time less than 2 seconds, really. You can have a listen for heart sounds. What we're talking about, oh yeah, shut down periphery. So you can see mottled skin, and you can feel a cold line as well. So the more and more shut down they are, the closer to the central body mass that cold line will be. So if you feel yourselves, you might have cold fingers, but your hands are usually warm. And the more shut down the child gets, you can sort of see, okay, they're cold up to the elbows, and then you start thinking about giving them fluid and providing fluid boluses, and you see that the cold line improves and it goes towards the hand. Someone's put here preductal and postductal. Do you want to explain what you mean by that?
It's when we measure the SpO2 and no, wait.
This
Yeah, we tend to measure oxygen sats, but
Yeah.
why? What is pre and postductal? What's the duct?
I think it can show us that if there's like any major heart or major arteries defect in the heart.
Yeah, so if we're thinking pre and postductal, we're thinking particularly a baby, usually in the first couple of weeks of life. And classically, if you're sort of textbook, it will be within the first, up to the first 5 days, really, is when the ductus arteriosus, as someone has put here, is starting to close. Now, in reality, the ductus arteriosus closes within a few hours. But in a baby with congenital heart disease who relies on the ductus arteriosus providing circulation to the periphery of the body, as in they might have a coarctation proximal to where the ductus arteriosus, and I'm not got any heart pictures, so I'm sorry, this is really hard to explain. There is a really good app called Heartopedia that I use to explain to myself and to my medical students, and actually to families. And they've changed it recently, but it's got slightly worse. But Heartopedia, you can look at all of the different heart defects, and you can look at coarctation. But essentially, the PDA ideally joins after the SNP, the constriction in the aorta, and you need that PDA then to provide blood to the periphery. And so, if your PDA is closing, is that right? Yes.
Yeah.
Then you lose peripheral circulation. And so the pre and postductal sats, the preductal sats are looking before the coarctation and before the PDA joins. And that is usually the right arm, as in most reliably the right arm, occasionally the left arm, but never do that. And what nurses often learn is you do the right arm and the left leg, but it doesn't really matter which leg. And so when one of your colleagues has put pre and postductal sats, we're thinking of small babies who'll come in clapped out, maybe cold peripherally, but they might still have a slightly pink head, and they might have a very cyanotic body kind of below the nipple line, particularly, and the right arm might have normal sats, but the left foot and the right foot will have abnormal sats. and that's where you've got a coarctation of the aorta and you're not providing peripheral
Yeah,
circulation.
I think there is like a criteria for that, that the difference has to be like more than 3 or 5 in some books, and it has like if one of the SpO2 sets are like under 95, I think, like it's a sign that there is something wrong.
Yeah,
So
so
yeah,
we
and you
tend to
repeat it twice, and
we tend to screen all babies. So we do this here routinely before they go home, and we would do a set of pre and post ductal SATs before they're discharged. And you're exactly right. So we would say SATs, both pre and post ductal, should both be above 95, and there should be no more than 3 percentage points different. So, you know, if you've got one 97 and one 100, that's fine. If you've got one at 96 and one 100, that's a, you know, that's a reason to go back and check. It may just be that actually your probe needs a bit more time to get a better reading, or you need a different probe. But you're absolutely right. I won't dwell too much on the neonatal circulation or the fetal adapted neonatal circulation, but congenital heart disease presenting within the first few days of life is often duct dependent,
yeah,
and that is
I
a
work
whole
at
other
the
area.
NICU, so I'm a bit biased. I just focus more on the neonates because I work at the NICU right now.
Okay. Yes. No, I mean, it's something to spend time over thinking about, and you need to have clear in your minds what the fetal heart looks like and fetal circulation, what the adaptions are for postnatal life, and where those congenital heart diseases rely on a duct-dependent circulation and where they don't, and also how those children are likely to present in terms of mixing um, of saturated and unsaturated blood, because some children will just be walking around with SATs of 85, 90. That's normal for them until they get their corrective things done. Let's move on, just because I don't want to do too much neonatology. I'm sure you've got other lectures hopefully on that. So what are we going to feel for apex beats, peripheral pulses? That kind of feeds into your PDA point, but we really love feeling for femorals, and one of our cardiology consultants loves talking about a 17-year-old he picked up obviously not a critical PDA, but sorry, critical aortic stenosis, but he did pick up an aortic stenosis. Actually, we picked one up not long ago on a 5-year-old who just came for a broken arm and came for surgery, and they had kind of cool, very poor pedal pulses, and obviously not critical coarctation, but it was there. And so, you know, there are people that will carry on with a coarctation that just will eventually need it corrected, but they will have some collateral circulation that allows them to manage. In babies, we always feel peripheral pulses. Things to measure, lots to measure, obviously, in circulation. So temperature, helpful because you want to correlate it with the heart rate. So children that are tachycardic, if they're tachycardic and afebrile, we would be much more concerned. And we are quite anxious. You know, we wouldn't send home a tachycardic child without a fever. Now, there's a big question about would you send home a febrile tachycardic child, but what we'd like to see is that we can get the fever down, as in cowpox. Obviously, fever does no harm. They have, as long as we know why they have a fever. So if you can explain the fever, they've got some sort of coryzal, snotty viral illness, and this time of year for us, it's all RSV and flu. But that explains the fever. If you can get the fever down with a bit of paracetamol, that's great. And then you would expect the heart rate to follow. And if it doesn't, then you're a bit more worried they're more unwell than just their coryzal illness. Blood pressure, like I said earlier, is a very late sign in children. So blood pressure, low blood pressure is a danger sign. That should be a red flag. And CRT is capillary refill time, which one of you mentioned. Well done. So capillary refill time, I would do it centrally on the chest, and that should be preserved longer than the peripheral refill time. So if you do a finger capillary refill time, you might find that it's delayed, but the central might be normal, and so you've got a relative reduction in circulation or circulating volume potentially. But if you are worried about circulation, particularly in younger children or podgy kind of well-built, well-fat padded children, it's very hard to get an IV access in them quickly. So there should be no hesitation in thinking about intraosseous access for difficult to access children, particularly when they've got poor circulation. Someone will come along to that child that you had to put an IO in an ED, and say, actually, oh, I put a cannula in the next morning, it was fine. You've already topped them up. You fixed the problem, and they've now got a beautiful, lovely vein on the back of their hand that someone else has cannulated. That is unfortunately the way of life, but putting an IO in should not be a hesitation. And we tend to say if you've had to think about more than 2 cannulas, we would go straight for IO. But if you're in ED, that threshold should be even lower. Okay, we'll whiz through the last one. So disability, we are looking for, this is mostly neurodisability, as I said earlier. So this is looking at low GCS. So these are children who are quiet, withdrawn, agitated, so abnormal movements. Agitation could obviously be psychiatric, but less commonly in children. And rashes is more for correlation with why. Listening, so they might be confused, they might be disorientated. This is big children we're thinking of. In terms of signs of meningitis, children are less forthcoming than bigger children and adults. So the smaller the child, the less likely they are. So the bulging fontanelle, obviously under 6 months, they still have a fontanelle. And you might feel a bulging fontanelle as a sign of meningitis. Neck stiffness, Koenig signs when you raise the legs up, unlikely to be present in smaller children. And so you've got less to go on for meningitis. And so actually just a very fractious, very irritable child is more concerning. Abnormal limb tone, so we're thinking more of upper motor neuron signs. Things to measure, obviously, so BM is another unhelpful acronym, but essentially means blood sugar. So we should be saying CBG. So capillary blood glucose. Pupils helpful to measure, and neurosurgeons always get very excited if you've measured their pupils, particularly if they're abnormal. AVPU is the simple version. I don't know if you've come across this already. So this stands for what does it stand for?
Alert,
verbal, pain, and unresponsive.
Yes.
Yeah, it's the sort of paramedics will use this often. Nurses might use this, but essentially, if they're only responding to voice, that's a much lower GCS. Pain responsive is roughly 6 to 8 is where you're thinking about needing intubating these children. And the PGCS is just pediatric GCS. Again, MediCalc or MDCalc have these. They're very, very, so, eye-opening is not something you need to be developmentally advanced for, is it? And positioning and following commands, a 4, 5, 6-year-old should be able to follow commands. So actually, there's not a huge amount of adjustment you need for these, but you can definitely get the pediatric versions for the younger children, and it's just a kind of common sense adaptations. And again, you're thinking about what you need to treat. So if they're seizing, then you need to give them anti-epileptics. Again, there's algorithms for this and how you approach someone in status or someone with the first seizure. If you think it's meningitis and you think it's an intracranial infection, then you give appropriate antibiotics or antivirals. If you don't think it is, or you think it might be, but you're not sure, then your imaging is obviously, it's not a treatment, but it's part of your diagnostic approach. And if the blood sugar is low, then you give glucose. And again, if they're difficult to access because they are vomiting because of raised ICP, raised intracranial pressure, and they're hypovolemic and they've got low circulating volume, then again, a very low threshold to put an intraosseous needle in. I don't know how many of you have readily accessible intraosseous needles, but we are increasingly comfortable, in the last 5 or 6 years with just going straight for them. We have a sort of electric gun that you can use, but there's also a manual one that you screw into the tibial plateau. We've got a picture in a sec. They are very, very helpful devices, and I would implore you to have some training on a mannequin of how to use these when you need to, or if you see someone else that requires putting them in.
Dr. James.
Yes.
Can I ask you a question, please? Quickly.
Of course you can.
Yeah, regarding the AVBU approach, it is not as accurate as the pediatric Glasgow Coma scale, isn't it?
The AVPU.
Yeah, is it accurate or
No? I mean, it's just a way of communicating to colleagues the level of consciousness someone has.
Yeah, exactly.
And it is very rough and ready. You're quite right. It's often
Simple.
something that nurses will use if they're less confident. Paramedics might use it. But if someone is only responding to pain, as in they are completely comatose and the only thing they wake up for is a sternal rub or you pinching on their finger, then you're concerned that their GCS is low.
That was my second question, which is how to elicit the pain. And you have mentioned this is sternal or the thumb. What about verbal? Just any voice? I just
so for
produce.
for small babies, running a thumbnail up their up the sole of their foot is quite effective because they will react to that.
Yeah.
Sternal rub is becoming less popular because you can leave a mark and it can be, you know, unnecessarily painful. So it's a bit of a last resort. Obviously, what you don't want to be doing is going to a child that's just asleep or, you know, miserable and causing lots of pain. So you start with the least painful thing. So pinching the fingernail, getting a pen out and pushing it against, you know, it's hard to put a lot of pressure on a fingernail before someone notices that it's painful.
Yes.
The go on.
And the V, verbal. Any noisy or any voice should I produce, or just specific one in a specific way?
So it's usually their name. So it's do they respond to verbal to voice? So if their mum is saying their name, so if they're saying Ibrahim and you wake up and you open your eyes, that's a verbal response.
Yeah, okay.
I think where
Thank you.
people often overscore these things, particularly, you know, GCS, is when someone's asleep, you do not have a GCS of 14, you're just asleep. Well, I mean, maybe you do have a GCS of 14, but it's not really fair to say that you've dropped your GCS because you're asleep.
I got it.
So you have to wake someone up, and if they can stay awake looking at you and, you know, cognition, normal cognition, and follow commands, then they have a GCS of 15.
Wonderful.
And
Thank you so much.
I think I'm sure you know this as well from adult medicine, but you know, the GCS is their normal. So this is about this is an acute score, not a chronic score. So to say that someone's normal GCS on their right hand side because they always have a fixed extensor posture on the right hand side because of cerebral palsy, their normal GCS on that side is always low is not fair or true. You take the best limb. So if they can follow commands with a limb but not other limbs, then you use that so it's an acute score. So it's a score of now but not what was happening last week.
Understood.
So if they always have kind of extensor posturing on one side, then that's not acute.
Okay, Dr.
Someone's
James.
put a comment here about which preferred after IV access failure, IO or central line. IO, definitely. I mean, I say this as a medic, as someone who's only done 6 months or so of intensive care. You know, if you're fab at putting a central line in, it's a slightly messy job. You want to do it as clean as possible. You want to get access very quickly. IO is your quick solution. That's your emergency department or emergency route of access, central access. Central line is once things have calmed down a bit. So if you're fab at putting one in 30 seconds, you probably want a job in anesthetics or intensive care. Well done. But for most of us, it's going to be an IO is the first line of access, as in backup. Actually, first line in some cases. So, and we didn't talk about exposure, but exposure is, for me, once you've kind of satisfied that most of those are normal or you're addressing them or you're doing something, you need to expose the patient. You need to see if there's any rashes, any kind of abnormal scars or trauma that you've not noticed. You need to feel their tummy and make sure the tummy is soft, because it's part that you otherwise ignore. So just to run through some basic, well, sorry, some not basic, but some common pediatric emergencies for us, and these may differ for you guys. But we see breathlessness a lot, and as I say, often that is viral induced wheeze, asthma, typically and occasionally pneumonia, not occasionally, but not infrequently a bit of bacterial pneumonia. Hypovolemia is very common, secondary to diarrheal illnesses, secondary to actually most diarrheal illnesses. Gastroenteritis is very common for us. Obviously, hypovolemia can be secondary to many things, including anaphylaxis, where the volume is in the wrong place. Sepsis is always something that should cross your mind if you've got a child with low GCS or a child who has poor circulation or a child who is kind of breathing very quickly and you can't quite explain it from the respiratory examination. younger children have, so particularly neonates under 28 days, have a highly permeable blood-brain barrier. There's a higher risk of DIC in those children, particularly for meningococcal disease. And sepsis in infants can progress quickly, particularly meningococcal disease, but they can also hold their own for quite a while before they suddenly fall off a cliff, as we spoke about. Seizures, so it may be the first afebrile seizure, and they may have epilepsy, or they may have one of many. I won't go into them. Pediatric epilepsy disorders, but there are a fascinating array. There are funny movements. There are febrile seizures, which are not at all uncommon. About 3% of the population will have a febrile seizure. 3%, a third, very common. And that, you know, that can be post-vaccine fever, that can be their first viral illness fever. Febrile seizures are a result of rapid change in temperature, not really the viral trigger. Some viruses just tend to cause you to have a rapid change in temperature quickly. Decreased consciousness has a wide differential, and I won't cover it in this lecture. Trauma, again, I'm not a trauma surgeon, so I won't cover that, but these are not uncommon for us to see in ED. And we've talked about this, but really, you know, I want you to be comfortable with ABCD. Look, listen, feel, measure, and treat. And it's sort of working through that, giving that as you sort of backbone of assessment, and working through your differentials. This is what makes you doctors and not algorithm-based practitioners. You're going to work through differential diagnosis and come up with a likely diagnosis and management plan. So how do we kind of risk assess children a little bit in A&E or over the phone when they call various departments, and we have triaging services here that sort of parents will call. And so these are some of these, this has come from our National Institute of Health and Care Excellence. So they give us lots of guidelines. So like I said, I wouldn't teach you how to do guidelines, but this is quite a helpful one. So this, I guess, again, is a framework in your mind of what you need to be worried about. So obviously the normal stuff is normal. And this is for looking for serious illnesses, but there is a traffic light system like this in our guidelines, which you're very welcome to have a look at. They appear on Google, for kind of fever, what is abnormal in terms of assessing a febrile child. But these are obviously red flag symptoms. So red flag symptoms are pale, mottled blue child. But actually, if they're just reported pallor and they now look a bit better, that may be a reason to come in and see you, but it may not necessarily be a reason to stay in hospital. Red flag signs for activity, we've talked about this, but things like grunting, high-pitched cry in babies. Parents will often say this, and you get a feel for it after doing a bit of pediatrics, but it's not a normal cry. These are the cries of children who are septic, or babies who are septic. They have an abnormal cry, and yeah, and just being clapped out. Respiratory, so we didn't talk about grunting actually as one of the respiratory signs, and that is the using extra kind of vocalizing effort to create positive end expiratory pressure. So that is with every out breath, they're grunting at the same time, and that creates a bit of PEEP. So that's a kind of physiological way that they're creating PEEP. Tachypnea, it says 50 here. Obviously, that should be age specific, really. And chest indrawing is the parent way of saying recessions that we were talking about earlier. Skin turgor is quite hard to assess. And what else have we got here? So fevers. I mean, fevers are fine. Like I've said earlier, fevers are okay. You need to know why the child is febrile. You need to know that they're well otherwise. So a completely well child with a fever that you know is caused by RSV because there's RSV going round, or they've had a snotty nose for a couple of days and now they've got a fever, but they're completely well in between and they respond to paracetamol. And this isn't a very small baby. This is a 9-month-old baby who's feeding and eating beautifully. The fever on its own is not the concern, but it's the fever with other signs. But here we're being conservative, but particularly the children under 3 months, we say that any fever is a risk of invasive bacterial infection, and we would want to assess those children. And for the slightly older but still quite young children, we still say that a relatively high fever of 39, we would want to assess them. This is about when the child gets assessed, not necessarily about how much you do for them. I just thought to highlight this website. This is one that we use quite a lot, and it's called Healthier Together. You can put in your local area, which obviously for you guys won't apply, but it doesn't matter really where you choose. This has lots of helpful advice for parents to look up on their smartphones, on the internet, when they're worried about something. So, they can click on allergic reaction. This one I've just clicked on for pain and, for fever and high temperature. And this is really how parents should be trying to triage and assess for themselves the child. We see lots of well children, and we see lots of children who come in a little bit later than we'd have liked them to. So ideally, we empower the parents to make good decisions. But we often need to help them, particularly if there's not other family around who've seen lots of children. Okay, so that is the introduction bit. I will move on quickly to sepsis and DIC, but in the interest of time, but do feel free to jump in if I'm saying things that sound mad. Okay, so this is a 7-week-old baby, and we talked earlier about babies under 3 months being more concerning. In the UK, we don't start our primary immunisation schedule until 8 weeks. So we also know this is an unimmunised baby who will have only had maternal vaccines in pregnancy. So they were born at term with an uncomplicated pregnancy. They're exclusively breastfed, and they've been unwell for a couple of days. They're now 38.8. They're called, this is our sort of online remote triage number, 111. And they've called that, and who sent an ambulance because no one trusts small babies to behave. And this is what the parents are telling you, that my baby won't stop crying and they've got a fever. So, are you worried? I think the yes in the chat box was an old yes, but yeah, we'll go with the new yes. Yes, I would be, absolutely. So this is a small baby who's now febrile, but also, this is the concerning thing from mum. They won't stop crying, so they're not behaving normally. They're clearly irritable, if you like. And someone's put here, yeah, sepsis until proven otherwise, and that's what locally that's the approach we would take as well. So obviously you need to do a full assessment, but we would say this is fever without a clear focus. It's sepsis. So we take fever under 3 months very seriously. So that's, for us, fever is over 38 or at 38 and above. Obviously, you can draw the line wherever you like, but that's where we've gone with. Ideally, that is a proven fever with an auxiliary thermometer that's reliable. It's quite tricky when you've got children brought in by parents and it's not really clear how they've established as a fever, or they've got some sort of zappy gun on the head and no one's quite clear. Sometimes we will hang on to those babies depending on how they look when they arrive. That said, as we've said here, we're concerned about meningitis, particularly in small babies. We're concerned about invasive bacterial disease. Often they turn out to be UTIs, so urinary tract infection. But often they present with non-specific, non-localizing symptoms. So that can be just going off feeds. They can be irritable non-specifically. So irritable is a bit of a red flag for meningitis. They might be vomiting with diarrhea. They might be tachycardic, tachypnic, and grunting. All of that, that could be acidosis driving this, not necessarily a primary respiratory problem. They could just be acidotic because they're septic, because they've got peripheral poor circulation. So children at this age, do not localize well. And the other reason that we're worried about these, we sort of hinted at with the fact that they're not vaccinating. EOS is our shorthand for early onset sepsis. So that is inferred to be within 7 days of birth, often taken a little bit earlier. But the suggestion is there that we're worried about vertical transmission. So that is anything lining the kind of the birth canal that they may have picked up, particularly group B strep in our setting. It might be E. coli that's colonized. So things like congenital pneumonia would be a concern. And obviously risk factors for early onset sepsis. So we're thinking of preterm labor, rupture of membranes for particularly more than 24 hours, but actually, useful to know because biology doesn't stop at 24 hours. That's a continuous curve. if there was chorioamnionitis suspected at delivery, if they were delivered because the baby was not behaving well, if there was abnormal fetal heart rates, and then late onset sepsis. So we're thinking of, this is usually postnatal exposure. We've got a list of the bugs in a second. But yeah, as we've sort of reiterated here, that the absence of these risk factors does not mean the absence of risk. This baby that presenting in the way they did is a risk in itself, so it doesn't really matter that you've lost these risk factors. A completely well baby with a 37.8 temperature and none of these risk factors, you might be a little bit more comfortable to watch and wait. And yeah, the normal disease pattern of late onset sepsis in babies is insidious disease that just appears sporadically and doesn't give you any warning, unfortunately, which is unhelpful for parents. This is just a list of the common organisms. So early onset, as we mentioned, for us, it's group B strep and E. coli, things that are around the birth canal. And then other kind of alpha hemolytic strep and enterococcal species, things that live around the kind of anal genital region, and less commonly group A strep, Haemophilus. And late onset sepsis, so group B strep still appears there because once babies are colonized with group B strep, and we don't screen in the UK, and a number of countries don't screen for group B strep, and even if you do, you may find false negatives. But once you're colonized with group B strep, you can present up to 3 months later with invasive disease. So those babies will just be colonized and may not be unwell early on. Later on, so we've talked about Coagulase negative staph, the cocci, although so it appears on this list, this is from a BMJ article. It appears on this list, but actually this is thinking really of babies on the neonatal unit who have plastic in situ. So it's not always indolent. It may be true infection, and yeah, you can see this list. But this is the late onset sepsis, but slightly conflated with neonates. Okay, so this is a slight guessing game. What are you going to look for in this child who's potentially septic at 7 weeks? Swelling, yeah. Where are you looking for swelling? Oh, swelling of the airway, sorry. Cyanosis, yeah. What have we said here? Vomit, potentially in the mouth. Appearance, yeah, so general appearance, I agree. This is more, sorry, thinking of airway. So colour, I would agree. Listening, there's not a huge amount to listen for, but the same thing as before, stridor. Yeah, pale, agreed. Feeling, nothing really to feel for. And if you've tried feeling a baby who has very little neck, you're not going to feel the trachea. Measure for the airway, very little to measure. I'll flip through these, but in terms of treating maneuvers, this is more about having a neutral head position. Irritability, yes, and I guess that's more to look for in general as opposed to the airway. So for babies, we want a neutral head position. That's because this isn't a very small baby. This looks more like a toddler. But babies, as I'm sure you'll have seen, have very large occiput. And so what you're really trying to do is put a shoulder roll in to keep that head neutral, as opposed to, you talk about infants and slightly bigger children, you tilt their head slightly further back well, the textbook will say sniffing the morning air. I don't know if that means anything to you. And then as you get older, you'll tilt the head even further back. But babies just need this neutral head position because the trachea will be in line with the rest of the body, and largely because they have this large occiput, and you just want a bit of a shoulder roll under there. Okay, looking for breathing. What breathing signs would you see on a septic looking 7-week-old?
Nasal flaring.
Yes, absolutely. I think we've got a video in a sec of nasal flaring.
Chest retractions.
Yeah, absolutely.
Different types of chest retractions and the symmetry of chest expansion.
Potentially asymmetry. I mean, often it's symmetrical, I have to say, but yeah, definitely. I mean, babies are very, very generous with their respiratory signs. All of the things you said there, you might see cyanotic babies, absolutely. But they will have very generous respiratory signs. If you see, for us, we're coming into bronchiolitis season, so babies have very generous signs of bronchiolitis. They will be working hard with their breathing. They might have recessions and retractions all over the shop. Yeah, breath sounds you might hear from the end of the bed. You might hear them grunting. You might hear crackles or crepitations. Absolutely. stridor we had on the last slide just for upper airway. Not much to feel for a small baby. You know, you don't tend to feel for the degree of asymmetry. And in terms of measuring, so you'd want to definitely measure the respiratory rate. Babies, so a presentation of particularly formerly preterm babies, so if they're ex-preterm, if they're born at 27 weeks and discharged at around term, their primary presentation with new respiratory illness is often just pauses in breathing or apneas, and so they might come in cyanotic for that reason. And that's because they have a poor respiratory drive to start with. And it's not an uncommon cause of babies who go to the pediatric intensive care who get intubated, ex-preterm babies who actually just turn out to be bronchiolitis and RSV. I'll see if these videos work in a second. So what you're going to do, you're going to give them oxygen. So does this work? Oh, maybe I need to get rid of the pointer. How do I get rid of that? Da, da, da. Go away, laser pointer. Let's see if this works. Here we go. Don't know if you can hear that your end, but that was a grunting baby, but you can also see some subclavicular recessions. And the grunting sound, so it's expiratory, and we talked about this as them creating their own PEEP, positive end expiratory pressure. You can probably just see a little bit of recession there. You can't actually see any intercostal recessions, and you can't see the trachea. And it sounds like you can't potentially hear anything, but you can, hopefully you can see some recessions. I don't know how to make it more audible.
Subcostal retraction.
Definitely some subcostal recessions there. And circulation in a septic baby. I'll whiz through these because otherwise I won't get a chance to finish the lectures. So there will be grey, mottled, potentially edematous. And that again is circulation just not going to the right places. Let's see if that works. There we go. You might hear an irregular or a fast heart rate. You might feel thready pulses. We talked about cold hands and feet, and that might go up the legs, that might go up the arms. So they're peripherally cold all the way to the elbows or the shoulders, hopefully not centrally. They will have a fast heart rate. They might have a low blood pressure, and you'd be very concerned. And those capillary refill times, we talked about central versus peripheral. And for small babies, a low temperature, so loss of thermoregulation, is just as much a sign of sepsis as high temperature. So although they presented at 38.8, that's our red flag for could this be sepsis. If you also find a baby that's 36 degrees, then you'd be concerned that that baby is not thermoregulating properly. And we talked earlier about how we would fluid resuscitate them, and we would also give obviously intravenous antibiotics, and there will be empiric antibiotics for you. And someone was asking just what type of breathing is that there? I mean, I would just describe that as respiratory distress, personally. Rather than abdominal breathing. I mean, with abdominal breathing, you're often sort of, it's paradoxical, aren't you? So you're pushing out your stomach in order to generate some negative pressure, which is not how you normally breathe. So usually if you breathe in, everything goes out together. But if you have to use your abdominal muscles to breathe, then that's abnormal. So disability, this is just thinking again about this septic baby. So they're not going to be as responsive as normal. They might have seizures and abnormal movements. And again, that might be electrolyte, that might be intracranial, that might be meningitis. They'll have poor feeding, irritable unsettledness. I mean, I feel like some of these things are not how to recognize a sick child. I'm hoping you would recognize these things. Some of them are a little bit more subtle, and these need to come out in the history. So they might have a high-pitched cry, which we talked about, but an abnormal cry, the parents will point out usually. They might have a bulging fontanelle, which will tell you potentially intracranial source of something, infection or bleed. See, we're thinking febrile and they've got a bulging fontanelle, you're worried about meningitis fairly early on. Things to measure. So we talked about measures of neurodisability. Sugar, definitely. Even if you think it's meningitis, you're going to measure the sugar because their sugar might be very high, which you don't need to do anything urgently for, but you'll need to think about. Or it may be very low and they've used up all of the glucose and glycogen stores they have. And treating, yeah, we've talked about, so you're going to give fluids and you're going to give antibiotics. In a second, we talk about the sepsis 6, which is a bundle that we use here to try and ensure that children get the right treatment. What is this supposed to be?
Baby has a severe skin infection and poor feeding.
So this is just a video suggesting a lethargic baby.
Here is a baby with convulsions and lethargy.
Cannulated.
This baby is lethargic.
I mean, I think
He doesn't react to stimulation.
This baby is not responding normally to.
He also has poor feeding. This baby has severe jaundice and lethargy.
And so, yeah, that last baby was clearly very jaundiced. The risk there would be of conypterus with jaundice levels that high. But jaundice and lethargy go together. So I'd be less concerned about a septic baby if they were completely otherwise well and they've just had increasing jaundice. But you need to treat the underlying cause and you need to know why they're jaundiced.
Baby has.
Okay. This is just rounding up on sepsis. A quick summary. We talk about give 3 and take 3. So we give oxygen if needed. And actually there's very little harm you can do in giving oxygen in children, unless they have congenital heart disease, and you would know about those children and think about them differently. Fluids, you give them early, you give them as required. We tend to slightly restrict fluid boluses in that we give 10 mils per kilo as required, but you assess the response and then you repeat if needed. And for us, we would escalate very early to seniors or intensive care, particularly a child presenting who we think septic, who's not responding appropriately. Antibiotics parenterally early, and we've talked about routes of administration. And ideally, you want to know what they're septic with. And so for us, that includes a full, what we call a full septic screen. And so that would be taking a blood culture, which you do when you put the cannula in before you give antibiotics. You take urine and then lumbar puncture. And that includes microscopy, and nowadays we do PCR on all lumbar punctures. So microscopy for cell counts, and obviously a white cell count is significant in a baby of 7 weeks old. No white cells really should be there, but under 28 days we expect some white cells, and we have some cutoffs for where we think they should be. People used to say you go at these children, these babies under 3 months with fever, they used to say you go at them with 3 needles. The first needle is for the cannula for the blood culture. The second needle is for the LP, and if they still haven't passed urine at that point, then you do a suprapubic aspirate. I mean, I think with an in-out catheter that's sterile, we don't. Well, I've not seen any of my colleagues do that, but that was the sort of the thinking. But if that helps you remember what you need those as a minimum, and you might also be looking elsewhere for secretions to capture. As in, do you need a chest X-ray? And the other things to think about going forwards will then be feeding, hydration, stool culture. I mean, I think you judge that based on so if they're dehydrated and they've had loose stools for days, then yes, absolutely, you could do that. If they've got bloody stools, then yes. If they're not having diarrhea, then no. I mean, for us, most invasive bacterial infection has nothing to do with salmonella or gut disease. So we wouldn't routinely think of stool, to be honest. But that somewhat depends on your setting, and it somewhat depends on the presentation. So most invasive bacterial disease is either for us UTI or upper urinary tract infection, meningitis or bacteremia, none of which is usually gastrointestinal in origin. And the last things to think of, what bloods are you taking when you're taking them? These would be at a minimum. And going forward, you're going to need to think of feeding and hydration. So if they're not feeding properly, but they might tolerate an NG tube, and then that's how you would feed them. Otherwise, IV fluids or IO fluids. And yeah, this is sort of colloquialism for a full septic screen you see people referring to, and certainly here talking about a full septic screen, and for us that's a full septic screen. Would body temperature affect the capillary refill time? Yeah, absolutely. I mean, they're interrelated. So the reason that children are, they're trying to make themselves febrile because it kills the bugs. We've evolved to do that. It kills bugs better. But as part of doing that, you centralize your circulating volume and you restrict peripheral circulation. So that makes you centrally hot, but it will make you peripherally cold. So if you take a central temperature, you will find that they are potentially febrile, but they're peripherally shut down and very cold at the time. And so adding to your difficulty in cannulating them. Okay, so slightly different case now. This is now an 8-year-old. So you're slightly outside of that danger territory of babies unimmunized with no immune system, who are much more at risk. But he's usually fit and well, and for the last 3 days he's been grumpy and febrile, and now he's slightly lethargic, eating less, and mum has noticed a new rash on his arms and legs. We had this massive campaign about this glass test, so we talk a lot about glass test in ED. Parents will come in saying they've run a glass over the rash and it didn't go away, and obviously to medics that is a non-blanching rash. So I mean, you don't need a glass, but he's here with a non-blanching rash and a fever. What is a non-blanching rash, out of interest? How would you describe that with some Latin?
What's the question again, Doctor?
So how would you describe a non-blanching rash to a colleague, or a rash that doesn't
Yeah, like the definition?
Yeah.
Okay. The non-blanching rash is that rash that does not disappear when we press on it by a transparent slide, and it is because the blood is extravascular, not intravascular. So if it is intravascular, when we press on that lesion or on that it's lesion like or that discoloration, if it's intravascular, the blood collection, or it will just find a way to go out of this area, but it is extravascular, it will still in that area.
Absolutely. And so what are they? How would you describe the rash? So different sizes have different names for this.
Yeah, great. There are 3 terms: the petechia, Berbera, and ecchymosis. The petechia is there are different textbooks saying different things and different doctors saying different things, but I know, really, but it's okay. This is acceptable. This is normal. The petechia is less than 0.3, Berbera less than 0.5, and ecchymosis more than 1 centimeter. There are others say that petechia is less than 0.5, Berbera less than 1 centi, ecchymosis more than 2. But what about you?
You're exactly right, and I agree. I see the same thing. Different places. Some people say less than 2 millimeters or 2 millimeters and less. Some people say less than 5. Essentially, a pinprick rash is your petechiae, and your slightly bigger but still small rash is your purpura. And as they start to become confluent, or they're just large bruises, that's your ecchymoses. You're quite right. And so I think, what I would be worried about, and what I would probably put on the record for this, if you've seen that at triage, you'd say that's probably a petechial rash, or a petechial or a purpuric rash. And that should be a red flag for a child who's febrile. So if they're febrile with a petechial rash, that's worrying. And obviously these pictures are lots of different things. I won't make you guess. So this is Henoch-Schönlein purpura. This is obviously meningococcal bacteremia. This I think is actually just trauma. So this is someone who's been coughing a lot and vomited, and then they've got an upper an SVC distribution of petechiae. And this one I can't remember what it is, but I think it was not. But all of these are petechial and purpuric rashes. This one you can see is much more purpuric and ecchymosis like, and we've got a definition there for all it's worth. But you're right, it's more just increasing in size. And the reason we worry about them is because they are a red flag, and we take them quite seriously, and I don't think outside of pediatrics people worry quite so much about petechial rashes, but we see lots of non-blanching rash as a presentation or as a cause to be seen, but they can be benign, and that makes it quite tricky. But we would generally treat them as worrying, and we would want to see those children, and you can't give any advice really over the phone when you're hearing about a non-blanching rash. And the worries are, meningococcal disease, purpura fulminans essentially is the consequence of meningococcal disease. It can be leukemia, so this can be a result of low platelet counts or very high white cell counts, but ultimately, marrow consumption, and you're then not able to properly plug leaking capillaries. And there are some slightly more benign causes. Obviously, you still need to make these diagnoses, and you still need to be able to work out why they're there. So immune-mediated thrombocytopenic, it used to be called thrombocytopenia purpura. It's now immune thrombocytopenia, because you don't need the purpura. HSP is henoch-shoreline purpura, so it's now renamed as IgA vasculitis. We see a lot of this. This is this sort of looks like meningococcal disease, but mostly on the lower limbs and the bum, and is usually an afebrile child who are completely well, 2 or 3 years old, running around the department, and they've got a petechial rash or purpuric rash that's been spreading for a couple of days. They might also have some tummy aches and pains because this is a vasculitis, so they can have kind of a bit of mesenteric adenitis. They can also have arthritis, particularly the ankles, and you would worry about renal disease with these children as well. But they are not the child that needs resuscitation, but they are presenting with a very similar looking rash. And trauma can do this. So obviously for us, we think about safeguarding a lot, and that is, is there harm done to the child by someone else, which is not always the cause of trauma. Trauma can be that they've been in a car seat with very tight straps, or they've got some particularly tight socks on that's caused some petechiae, and SVC distribution we talked about just now. So that's the sort of coughing, vomiting. They've got lots of increased pressure at that stage, and it's all retained in the head and some burst capillaries. And so that, that is a good explanation, and we would be a little bit less aggressive at treating those children, but we still need to see them and make that decision and diagnosis. There is a really, really good module on this website, which is also excellent, and I don't think is particularly UK, well, not entirely UK focused. So don't forget the bubbles do lots and lots of educational resources about pediatrics, and they have a whole module on the non-blanching rash. And you should not have to pay anything. Don't end up paying anything for this, but that's all there for free to access. Just Google. That said, we take fever and non-blanching rash, again, much like that baby with a fever, as sepsis until proven otherwise. And so you've got to do some work to prove that it's normal. You've not got meningococcal disease or DIC from another cause. And so this is DIC, so this is disseminated intravascular coagulation, which is massive, massive inflammation, consuming all of your coagulation cascade, and resulting in the inability to clot small vessels. And so you get this microangiopathic hemolytic anemia with consumption of the coagulation pathway. And yeah, these slides are written by a hematologist, so she's gone into detail. But you can obviously end up with limb-threatening disease or tissue-threatening disease, and it's not good. And obviously AKI. So these children end up on ITU, and it can be caused by invasive bacterial disease, can be caused by major trauma or burns, and obviously can be caused by malignancy. So DIC, something I think other people use. DIC, death is coming. Not great, is it? And it's hard to miss this, but this can rapidly progress. So it can progress from petechiae and purpura over hours. You don't want these children sat behind a curtain and you suddenly realise that they've progressed. Right, I'll whiz through these because it gets a bit tedious going through all the same stuff again. So what we're going to see for a child in DIC, probably not a great deal. Perhaps they'll be vomiting, perhaps there might be blood in their mouth because they're not clotting properly. Listen, you might hear some stridor if they've lost their GCS. Nothing to feel, measure, or particularly treat. I mean, you can manage the upper airway until help arrives. See on breathing, again, it's going to be potentially a result of the acidosis. They might be working hard. These are all fairly familiar. Breath sounds, you know, this might be crackles because pneumonia is the primary focus causing the DIC and the invasive disease, and it might be kind of pneumococcal invasive disease. And again, we're going to treat in the same way with oxygen and intubation if required. I think we've gone through all of this, to be honest. So look, they're going to be grey, they're going to be mottled, they're going to be pale. You might hear new murmurs, you might hear a tachycardia or potentially a new irregular heart rhythm. They might have thready pulses and cold hands and feet, which we've already talked about. All of those other features we talked about, and you need to do all of the same resuscitation you would for a septic child. We have this Septic 6 campaign, which we talked about, take 3, give 3. So the 3 that we take, so we take blood cultures, we take a lactate because it helps guide a little bit management. So a lactate over 2 is concerning, a lactate over 4 is very concerning. Urine output is helpful to be able to monitor. That said, we're pragmatic in paediatrics, so if they are still peeing in a nappy, we weigh the nappies. We don't always catheterize them. If they're heading towards PICU, then yes, absolutely, you've got lines and catheters going in. And the give 3, that is give fluid. And if you are in fulminant DIC or you're septic, you're going to be giving initially boluses of IV fluids. You're going to give a broad spectrum antibiotic. We start with a cephalosporin, but you know, obviously that would be based on local guidelines. And we give high flow oxygen because we think they're going to have poor organ perfusion if they're septic. This is just a kind of example of a delayed capillary refill time. So this, you can imagine pressing down for 5 seconds, 4, 5, and it's still quite pale. So delayed capillary refill time. And this is a snapshot of a YouTube video of someone putting an intraosseous needle in. It's well worth a watch. They come in different sizes, these needles. The blue ones are the smallest ones for children. This is a sort of electric device, but you can, as I say, you can get manual IOs. It's worth seeing. There are, I think, videos of American soldiers kind of drilling into the humerus to put these in on themselves. So they are less painful than you would expect. And if a child is already very unwell and has a decreased GCS, they're not going to feel it. You do not need to use local anesthetic. You need to get this in, resuscitate and treat the child. There is a bit of pain on the periosteum, but beyond that, honestly, they really do not respond particularly as much as you would expect. So yeah, we would encourage early IO access if that's your only route of access. So this is thinking about a child in DIC or fulminant sepsis. So it's as before, essentially, and the rashes are going to be key. You need to expose the child. They might be disorientated. They might have, you know, so if this is true meningococcal disease with rapidly progressing DIC, they would have potentially would have signs of meningococcal sepsis as well, meningitis as well as bacteremia.
Meningism,
thank you.
Yeah.
And they may well be some in the history as well. Just because they have meningococcal bacteremia does not mean they're meningitic. And just because they have meningococcal meningitis does not mean you're going to see the rash. But there is concordance, and sort of about 80% of children with meningococcal disease also have meningococcal meningitis.
Yeah.
This is a poorly responsive child.
Let's score this event. Yeah.
Don't think they show much other than you can hear them if you could hear them talking about this child, and clearly he's not responding in a normal way for a child of that age. And you can appreciate it, you know, this is not normal. So that's a child with low GCS. This is, and these are all just off YouTube. Demonstrating Koenig signs. So this is when you lift up the neck, the whole of the body comes with it. So the whole of the torso comes with lifting the head. They have that degree of neck stiffness is a stiff neck. It's not that it's just painful to do that movement. Everything comes with it. Oh, you've got to watch this one. This is obviously the people are stage. Okay, so last child. I think I won't go through this, but this was someone's personal example of someone they were worried about who deteriorated very rapidly, and I think we've gone through that. We use these Pew scores, which can be quite helpful in sort of charting how worried one should be about a child. So they obviously need to be age appropriate, and they can be done electronically or they can be done on paper. And essentially, usually the nurses who are doing the regular observations will then be able to plot. So this is heart rate and blood pressure. So if you plot where the heart rate and the blood pressure is, you plot where the respiratory rate is, you can plot, so you essentially say degrees of respiratory distress. There is one down here for parental concern or nurse concern, so that gets you extra points. We don't use temperature as a guide because just because they're hot doesn't mean they're necessarily septic, and just because they're septic, they won't necessarily be hot. So that doesn't particularly help. And this isn't just a sign of sepsis, but this is a sign of the unwell child for any reason. And we use it as a partly as a tool for the nurses to empower them to escalate, but also as a tool to monitor how sick a child is and what the progress has been since some interventions. And so you can see the higher they score, if they have a Pews of 5 or more, you need to be talking to the consultant, and the nurse in charge needs to be aware. And so, you know, this is everyone, all hands on deck. But even relatively raised Pews, you know, a 3 would be a tachycardic child, which may be due to the fever, but they've scored. So however they score, with a bit of breathing distress and requiring a bit of oxygen, they already score 3. So they get an urgent doctor review because of the Pews score. And that is just a tool to help people escalate appropriately that we find quite useful. Oh, there's all the writing, sorry. I think we've said that. The downside is, children can hold on for quite a while before they fall off a cliff, which I've said a number of times. Sorry, it's the thing that appeared on my screen there. Fluid boluses, we'll talk briefly if we can about fluids. I don't know if I'm going to run out of time, but essentially you can keep giving fluid boluses, but we need to think about why. We give fluid boluses at 10 mils per kilo, and you look for a response. And if you're not getting a response, even a small response, then you want to be worried about why you're not getting a response. Is it that the fluid is in the wrong space? And so actually you're not fixing anything with fluid, and that could be because they're in heart failure, because they're so intravascular leaky, because the sepsis is so severe that actually they either need more filling or they need proper inotropic support or kind of vasoactive medications to keep fluid in the right space. Or could they be anaphylactic and they're also leaking for that reason? What else have we got on here? Yeah, we've talked about this really, haven't we? So yeah, just because they're purpuric and they're not meningitic, or because they're meningitic and they're not purpuric, doesn't mean it's not meningococcal disease or any other meningitis. Most meningitis does not have a rash, and actually we pick it up because of the meningism or because they're unwell, febrile, and we keep looking for a source. Yes, LP can wait. So if they're too unwell for an LP, then they can wait. You don't delay antibiotics to do a lumbar puncture, and we find actually quite good sensitivity now with CSF PCR, and so we can pick up most of the common organisms from that. That said, we'd like a sample as soon as we can. To grow it is much more preferred. And you don't want to be treating in the blind. And we've talked briefly about the sepsis cyst that has been a big campaign in the UK, I think internationally as well. Okay,